Good afternoon. I'm Lisa Randall. I'm a consultant with NASTAD, and I will be facilitating the webinar this afternoon. Welcome to Advances in HIV Testing and Strengthening Linkages to Care. I want to cover a couple of housekeeping notes before we get started first. And Jasmine, unfortunately, it does not seem to be allowing me to take control.
All right, let me see if I can designate that to you. Try again, Lisa.
It does not seem to be going. Can you, if I do the next slide, are you able to do that for us?
There we go.
All right, so just a couple of housekeeping notes as we get started. The webinar is being recorded. You will receive information after the webinar with a link to the recorded webinar, along with some handouts that are also posted in the handout section on the doc for the webinar. Everyone is muted except the presenters, and we will be holding questions until the end. We do encourage you as we go through the content today to go ahead and use the chat function as you have questions. And we're experimenting a little bit today with this new platform. We are going to try to open the lines towards the end if you use the raise your hand function if you have a question, but we will be relying primarily on the chat function. If we're not able to get to all of the questions that come in today, we will follow up with submitters after the fact. At the end of the webinar, we will also be releasing a very brief evaluation at the end, and we would very much appreciate you taking a couple of minutes to complete and submit that evaluation so that we can tailor future webinars and other technical assistance. So for the learning objectives today, it's very simple and straightforward. It's to describe current and emerging HIV and hepatitis C testing technologies and to identify challenges and opportunities for using these technologies to advance your programmatic goals and objectives. Next slide, please. I'm very pleased to present today our presenters, Monica Parker, who is the Laboratory Chief of Bloodborne Diseases for the New York State Department of Health Wadsworth Center Laboratory, Barry Bennett, who is a technical consultant for the Florida Department of Public Health Laboratories. He was formerly the Retrovirology Chief for the Bureau of Public Health Laboratories, and he is easing into retirement with us today. Anne Gaynor, who is the manager for the HIV, hepatitis, STD, and TB programs for the Association of Public Health Laboratories, who is our collaborator today in this webinar. And after Monica, Barry, Anne, and I have some time with you, we will open it up for questions and discussion. We have a tremendous amount of content today to cover today, so I won't belabor anymore, and I will turn things over to Monica Parker.
Okay, thank you, Lisa. I'm just going to wait for my slides to come up. Ah, good. Okay, and it looks. Let's see if I have control. Okay, good, and I seem to be able to control them. All right, great. So the objectives for this part of the webinar are going to be to discuss the characteristics of the currently available HIV diagnostic tests, with the hope that we'll all understand the recommended testing steps for the laboratory and point-of-care testing that's performed, and try to learn about some of the ongoing and new challenges in HIV diagnostic testing. And I'm going to start by providing some general information about clinical tests and how they are regulated. Oops, uh-oh. I seem to have lost the ability to advance the slides.
Can you try again, Monica?
Yeah, let's see. It is not with the arrow keys.
Can you toggle the mouse and see if that works?
Yeah, I'm doing that.
Okay. Let me try one more thing. Will you please give it another try?
No, it's not working.
Okay. If you just indicate advance or next slide, I can.
I'll just say next, and if you can click it, because I think there is, like I said, there's some animation that'll show up. Okay. Next slide, please. Okay. So when a test is developed for clinical use, the manufacturer needs to validate that test for specific claims that they plan to make when they're going to submit to the FDA. And those claims are going to include specific conditions, so that might be including things like the purpose or intended use. So either the test will be used for diagnosis or for screening donated blood, for example, or it may be indicated for screening or supplemental use. They'll also specify the type of result, whether it's qualitative or quantitative, as well as certain specimen types and collection conditions that they have validated for. They also might specify whether it's pediatric, adult, all those types of conditions. And then when the test is approved, it is limited to those specific conditions. It is certainly possible for a test to have more than one claim. So if the manufacturer submits for different types of claims, they can receive approval for those. But the FDA can only review the data that are submitted to them, and they can only approve the test for the claims requested by the manufacturer. And so this sometimes runs into some frustrating issues because there might be some very nice research studies done that are published in good journals showing how the test can be used under other conditions. But that process for publishing scientific research and regulation of in vitro diagnostic devices are very separate processes. And so we really are limited to what the test is approved for. Next slide, please. Okay, so next I want to review some relatively recent updates to the recommended terminology that we'll use to describe the different categories of HIV tests. For years, it's been the convention to refer to HIV tests, especially the screening tests, as being part of a particular generation. Like in 2010, when the first HIV antigen antibody combo test was FDA approved, this became known as a fourth generation screening test. Click or next. Okay. And however, this use of these generation terms over time have kind of become muddied, and new generations were being introduced that were maybe designated by test manufacturers, and in some cases those could be misleading. So they might be a higher number generation, but it didn't necessarily line up with what the test was capable of doing in terms of its sensitivity, for example. And so the CDC initiated the use of a terminology that's based on the methodology. So next, please. Meaning, for example, whether it's a laboratory-based test or a point-of-care rapid test, and also the targets that are detected by the test. Next. And these might include whether it can detect antigen or antibodies to HIV-1 and HIV-2. And I realize that this terminology is a bit more technical than the generation terminology, but it really is much less prone to misinterpretation. Especially when we discuss things like the performance characteristics of the test and when we discuss things like window period. Next. In the category of diagnostic screening tests, there really are a lot of different options to choose from, and it can be a little bit challenging to figure out how best to choose these tests. So to help with this effort, the CDC has compiled a lot of information on the different screening tests in a very useful document that's entitled Advantages and Disadvantages of FDA-Approved HIV Assays Used for Screening. And this can actually be accessed at the link at the bottom, but there's also a resource page that you all have access to, which will include this document as well. This includes a chart that lists all these different features of each test, and I don't think you can see them all here, but when you look at the document, you will see them. It includes things like what the test will detect, how much time it takes to get to a result, and if it's run on an automated instrument or if it's a single-use device, and also the approved specimen types. And then further along in the document, you'll also see for each sort of category of test, there'll be bulleted advantages and disadvantages of each test. So I encourage you to look through that and get a sense of what types of tests are available. Next slide, please. All right, now let's turn to the recommended laboratory algorithm for HIV diagnostic testing. And I'm going to just briefly walk through this, and then we're going to break it down into its different steps. So in step 1, the laboratory recommends that we conduct a antigen-antibody combination immunoassay. And if that is reactive, the specimen is then tested with a supplemental HIV 1-2 antibody differentiation test. And then if step 2 is positive for HIV antibodies of any type, then the testing algorithm is complete and the person should be referred to care. But if step 2 is either non-reactive or if it's indeterminate, then you need to go on to an HIV-1 NAT. That's the next recommended step. And if that is positive, it basically confirms infection, and it's likely an acute infection. And then if the RNA, it's usually an RNA test, is not detected, then the interpretation would be that the HIV infection is not present. Under most circumstances, that would be the interpretation. And so this algorithm was initially recommended by CDC in 2014, and then an update was released in January of 2018. And that update was provided because of a couple of different changes that had occurred. One was that the CDC had announced that the allele-determined HIV antigen antibody combo rapid test could be used in step 1. When the 2014 recommendations came out, that there wasn't enough data yet to support that, but that was allowed now only with serum and plasma specimens when performed in a laboratory. And the other change was that in the HIV antibody differentiation immunoassay, we had a switch in test. So the multi-spot was no longer available, and a new test was introduced called Geenius, and we'll talk about that later. But because of that change, there were also some new test results that were not previously addressed. So those had to be incorporated into the updated algorithm. So we'll continue with that later on. First, next, please, we're going to focus on the step 1. Next. Okay, so here is a list of 7 FDA-approved antigen-antibody combo immunoassays that may be used in step 1 of the laboratory algorithm. Next, all of these are designed to detect the HIV-1 P24 antigen and antibodies to HIV-1 and HIV-2. Next, 5 of these 7 do not distinguish between antigen and antibody, and then the result will either be just reactive or non-reactive. Next. And then there are 2 of them that do provide separate results. The allele-determined rapid test detects antigen and antibodies separately, and the Bioplex antigen antibody assay provides a separate result for the P24 antigen, for HIV-1 antibody, and HIV-2 antibody. Next. And I do want to just make a note that none of these tests are designed to detect HIV-2 antigen. And so this means that they can detect acute and established HIV-1 infection, but only established HIV-2 infection. Next. I'm going to just digress a bit from the algorithm just to discuss some of the window periods of these tests, because this is something where there is some new data available that can help us understand the sensitivity of the test. So first, let's just define window period, which is the length of time from exposure to detection of HIV infection. So knowing the window period for various HIV tests can be helpful for clinicians and counselors, but everybody always wants to know what the window period is, but we always have to keep in mind that there are many factors that can affect this, and for any given individual, there could be differences that veer from what maybe the average is. And so we always need to always keep that in mind and understand that there's really a range rather than a very specific window period for every test. However, the CDC did conduct a study to try to give us a better estimate of the window periods of the available HIV tests. And this really is a kind of a tricky thing to do because we don't always know the exact time of exposure. And so having very specific sets of samples where exposure is known can be helpful, and these are referred to as seroconversion panels. And the CDC did have those available for this study. So the first thing they had to do was to calculate the eclipse period. And so this is the period of time that is designated from exposure to when the very first HIV test, the most sensitive test, can detect infection. And that is typically an HIV-1 RNA test. So this was done basically using a lot of data and modeling to come up with an estimated eclipse period. And then using this information from when HIV-1 RNA could be detected, they measured the time when all of the other tests could be detected after that and came up with a range for each type of test. Basically, they had a number of different longitudinally collected plasma samples from several different, quite a number of different HIV-1 people who had seroconverted, over 200 samples in all. And then they did measure the time from which sample RNA could first be detected to which sample they could have reactivity on one of the immunoassays. And these tests fell into different categories. So they were the laboratory-based antigen antibody test, the laboratory-based antibody-only screening test, point-of-care rapid tests, and supplemental tests. Next. So this slide really summarizes the main results of this study. So just to give you a little sense of what we're showing here, the oval represents the median for each different test category of when it became reactive. And then there's a thick bar that shows the interquartile range for the 25th and 75th percentile. So using the data from this study, the eclipse period, which is basically the time to RNA detection, was estimated at 11.5 days. And the median time to detection for the laboratory-based antigen antibody immunoassays was 17.8 days. And the antibody-only lab-based tests, it was 23 days. And for the antibody-only rapid tests, it was 31.1 days. So that's, again, it's a median, and there is a range. And then the dotted line actually represents the 99th percentile. Next. Also in this study, the CDC looked at the available CLIA-waived point-of-care rapid test. And you can see from the list here, starting at the top, you can see the median estimated window periods for each of these rapid tests. But one thing I want to point out is when this study was done, all of the testing was performed on plasma samples. And so there can be differences based on the specimen type, and it's something we'll come back to in just a minute. Next. And so if we return back to this visual again, we want to look at maybe where the determined antigen antibody rapid test falls in. And so I placed that data on this slide, and you can see that the median for the determined here is 19.2 days, so it's not quite as sensitive as the laboratory-based test. But again, this was using plasma samples. Next. And I bring that up because, as I've mentioned, specimen type needs to be considered when you're evaluating rapid tests. So in another study, the determined time to detection was compared for plasma and for simulated whole blood using similar seroconversion panels that had been previously tested using a laboratory-based antigen antibody test. And of those samples, the determined detected about 91% of the same samples as the lab-based test for plasma, but only 56.4% when those were in whole blood. And so that's a sizable difference. It was a significant difference. And the authors, there was a number of other results from this test, and overall they observed that when determined was used on whole blood, there was definitely a marked reduction in antigen detection, and also there was a significant delay in reactivity compared to when the test was performed on plasma. And this is one of the primary reasons why when the CDC said it was okay to use determine in the laboratory algorithm, that they specified serum and plasma and not whole blood. In another study, which I'm listing the results on the right of the slide, this was a part of the APHL HIV net project, and using samples from that, there were serum specimens from 125 acute HIV-1 infections that were initially identified by a laboratory-based screening assay, and they were defined as acute by the results of the testing algorithm. And then these samples were retrospectively tested with determine. And of those, only 65% were reactive on determine, which would indicate that there would be a significant number of these infections that might have been missed if determine had been used as the screening test. So it's just something we want to point out, especially because we tend to lump together antigen antibody combo immunoassays all together, but there are differences between the rapid test and the laboratory-based test that can be significant. Next slide, please. So this is back to our laboratory algorithm. So next, we're going to move on to step 2. Next. So we only have, unlike the screening assays where we have a lot of different choices, we actually only have one test that is currently FDA approved for use as the step 2 or HIV 1-2 antibody differentiation test that is approved for supplemental use. And so this is the Geenius. It's produced by Biorad, and I'm showing a picture of it here. It is a single-use device cartridge. It has a number of different bands. 2 of them will detect antibodies to HIV-2, so those are the GP36 and the GP140, and 4 of them will detect bands to HIV-1, so P31, GP160, P24, and GP41. And then there's an internal control band that verifies that the sample was absorbed appropriately on the test. It's very simple to perform and has results available within 30 minutes. And you can see in the bottom of the slide, there's a picture of a little instrument, and that is the reader. And the cartridge is inserted into the reader, and it uses FDA-approved software to interpret the results of the test. So unlike the way we used to perform Western blots, which was very subjective and laborious, this is a very simple and quick and objective test to perform. Next, please. But although the Geenius test is very fast and very simple to perform, it does produce some somewhat complicated test results, and so I'm just going to take a minute to talk through those. So if there are bands that are present, the test will be detected, and then the software will also measure the relative intensity of those bands, so it's taking an image of them, and then it will provide in the results page a result for both a separate result for HIV-1 and HIV-2. It will let you know whether there was any reactivity detected in 1 or 2, and actually on the results printout you also see which specific bands were detected. And then the software looks at all that data, analyzes it, and produces a final assay interpretation. And so that's shown on this diagram on the left. And that is really the Geenius test result, is that final assay interpretation. The individual HIV-1 and HIV-2 results are really considered intermediates along the way. And so in this example, you can see that the HIV-1 result was reactive for antibodies, and the HIV-2 result was indeterminate for HIV-2 antibodies, but the overall final assay interpretation was HIV-1 positive. And this can happen in cases where there's a very strong HIV-1 antibody response and there's some cross-reactivity that might cause one of the HIV-2 bands to show up, but the software can determine that is cross-reactivity and not HIV-2 antibody specific. The test instructions make it very clear that you should always report that final assay interpretation, because this is really the final result of the Geenius test and the one that should be used in determining next steps. But also everybody should keep in mind that that is the result only of the Geenius test, and that when making an overall interpretation, really all the test results need to be considered from the laboratory algorithm. And so although they refer to it as a final assay interpretation, it is only final for that particular test. There may be more test results that need to be considered, especially if that was indeterminate or non-reactive. Next. And I just want to mention that there is a very nice document that was put out by APHL, the Suggested Reporting Language for HIV Diagnostic Testing Algorithm, and this link is here and is also will be on the resource page. This was released in January of 2019, and it was taking into account some of these new updates that have taken place, so ones related to the Alere determined test and the update of the quick reference guide for the algorithm. And also there is more clarification on the reporting of Geenius results and some of the atypical results that might occur with the Geenius test and how to handle those results. So I encourage you to look at that as well. Next. All right, so as I mentioned earlier, if the Geenius test is positive for antibodies, then the testing algorithm is done. If the Geenius final assay interpretation is either non-reactive or indeterminate for any type of HIV, then the next step is to conduct an HIV nucleic acid test. Next, and next. Okay, and so with HIV-1 NAT, we also have we are quite limited in what we have available to us. And the Aptima HIV-1 RNA qualitative assay is still the only NAT that is FDA approved specifically to aid in diagnosis of HIV-1. We have FDA approved HIV-1 quantitative assays, or also known as the viral load tests, but so far those are only approved for monitoring patients on treatment. And this is a limitation that it makes it difficult, even though we know that those tests are very robust tests and very sensitive. But for a laboratory to use that in a diagnostic algorithm, they would have to do additional validation studies to allow that to be used because of the regulatory constraints. And so because we're limited in what HIV NAT we have available to us, this can often extend the time to result and may delay the diagnosis of acute infection. Next. And so some of these issues that we have with timely detection of acute infection could be improved if we had simpler, faster NAT tests available for diagnostic use. And some of these types of tests actually are available and are used outside the U.S., but so far none of these are approved for use in the United States. The test platforms are designed to require very little hands-on work, so they're referred to as like sample in, result out. Mostly the sample is added and the machine does the rest. And the advantages are that they are very fast, and they could even conceivably be used in a variety of settings, including point-of-care settings, and that could potentially improve linkage to care. So you may want to know, when will these tests be available in the U.S.? And I honestly do not have an answer, but my understanding is that we still have at least a few years to wait till we have access to these tests. Next. I want to just briefly mention HIV-2 nucleic acid testing. If a specimen is repeatedly HIV-2 indeterminate or HIV indeterminate on the Geenius test, the recommendation is to perform the HIV-1 NAT. And if that is negative, there are really two options that you have left. So one would be to perform a different HIV-2 specific test, either an antibody test or a NAT, or repeat the algorithm with a new specimen in 2 to 4 weeks. The problem is that there really aren't any HIV-2 NAT kits available in the U.S. There are a couple of validated laboratory-developed HIV-2 NAT tests. One of those is available at the Wadsworth Center for New York State patients or for out-of-state patients if there is a contract in place. And the other is at the University of Washington's Department of Laboratory Medicine. So there is some limited access to HIV-2 NAT. In most cases, when somebody is HIV-2 positive, the Geenius will confirm that, but there are cases where we have these indeterminate results that still need to be resolved. The lab algorithm really does identify HIV-2 infections quite accurately, but because of these indeterminate results that we get for HIV-2 that will sometimes persist, this has led to quite a bit of additional testing. So that's something that we hope to improve upon in the future. Next. So challenges, yeah. So we have a lot of options for the supplemental, we have a lot of options for screening tests, but we are really limited in the options that we have for our supplemental testing steps of the algorithm. We definitely need more, including faster NATs and simpler NAT tests so that we can get those acute infections diagnosed more promptly. So those are a couple of ongoing challenges that we've been dealing with for a while. In addition, testing of people who are on antiretroviral drugs is creating some new diagnostic challenges, and we're starting to see these a little bit more frequently these days. Next. So PrEP, pre-exposure prophylaxis. I think this group is probably aware that a daily dose of Truvada can be highly effective for preventing HIV infection, and it is recommended for HIV-negative people at high risk of becoming infected. For testing prior to starting PrEP and for monitoring during PrEP, the CDC guidelines list rapid tests and antibody-only tests as options, but, and I put this in bold, that they really recommend use of the laboratory-based antigen antibody test. These are preferred because of their enhanced sensitivity. HIV infection can occur when PrEP is not taken consistently as prescribed. Next. Next slide, please. Okay, thanks. And so when you're trying to do testing, if somebody is on PrEP, this can impact the test's ability to detect HIV infection. So virus may be suppressed to low or even undetectable levels by the PrEP antiretrovirals. That may mean that antigen antibody test results can hover near the cutoff and fluctuate from reactive to non-reactive on successive specimens. And likewise, we've seen that HIV-1 RNA levels might also fluctuate between being detectable and undetectable, and you can have these discrepancies over multiple blood draws. And it can be a little bit challenging to sort out what might be going on in these cases. Additionally, seroconversion may proceed more slowly than usual, which will delay detection by the antibody-based test. And so because of these challenges, and we do from time to time have to use diagnostic testing while people are on PrEP, we realize that there might be additional tools that we need, and one of these would be an HIV DNA test. We don't currently have any of these available that are FDA approved, so we'll have to rely on laboratory-developed tests in those cases. Next slide, please. I'm going to make a few final points before I hand this over to Barry. So from my section, I hope we've understood that many different HIV screening test options are available, and you have to consider the sensitivity, the speed, and the setting that you're going to do the testing in when choosing the best option. We definitely have more accurate estimates of the window period thanks to some new data, and that can be helpful in guiding our testing decisions. But despite many available HIV testing options, we still have a lot of limitations and challenges. And because of all this, I do encourage you to use your public health laboratory as a resource. If you have questions or situations you want to discuss, certainly contact them. They're usually willing to help. And with that, I am now going to hand things over to Barry Bennett to talk about HCV testing.
All right. Thank you, Monica. Wait to see if Jasmine, I think I'm in the same position. I'm not advancing.
All right, Barry, let me see here. Oh. If you try it once more.
All right. Nope, doesn't look like it. So let me just get started and I'll let you advance them for me. Good morning, good afternoon to those of you on the call. And thank you, Monica, for very comprehensive coverage of the HIV update. It's my privilege to add a little bit more about the HCV diagnostic testing. So I do appreciate NASDAQ and APHL for putting on this webinar. Next slide, please. Very timely call today, since we're in the midst of Hepatitis Awareness Month, and by my calendar, at Sunday will be the Hepatitis Testing Day. So next slide, please. So the learning objectives for this portion is to review the indications for HCV diagnostic testing, understand the window periods for the HCV assays, and to learn about new directions and challenges in HCV diagnostics. Next slide, please. I just wanted to add this illustration to show the potential clinical consequences of an HIV and HCV infection upon a person's normal liver. Most individuals will transition from acute to chronic infections in about approximately 6 months. And of those, 20 to 30% will move to cirrhosis over their lifetime. And unfortunately, 2 to 7% of those individuals will experience end-stage liver disease and perhaps death. It's important to note by this illustration that this progression may take decades to get to that end. So hopefully, with some of the new guidelines that we're going to talk about, and clearly the highly effective antiviral therapy, we can interrupt this progression in the acute or early chronic stages, and thus avoid some of the poor clinical outcomes. Next slide, please. So if we start with acute HCV infections, approximately 80% of the people who become infected will have no symptoms or nonspecific symptoms. Hep C is usually not diagnosed in the acute stage, even with we're going to see with the algorithm that is currently being used, it's not really designed to pick up the acute stage. But those that we do diagnose during this stage, they're usually manifest as a positive or quantifiable HCV RNA as result with a negative HCV antibody. Or you could have an HCV antibody reactive preceded by an HCV antibody negative in the 12 months prior. It's also estimated about 15 to 30% of the HCV infections will clear spontaneously. However, there's literature that estimates that these rates are lower among people who live with HIV, probably in the range of 10 to 12%. Approximately 90% of those that clear will do so within 6 months of exposure, so they never get to that chronic stage. The RNA will become undetectable, the ALT levels will return to normal, but antibodies will persist. Next slide, please. So the remainder of these cases that we just talked about, the 15 to 30% were acute, so the remainder are chronic infections, 75 to 85%. And they're usually signified by detectable or quantifiable HCV RNA level for more than 6 months after the onset of the infection. The liver enzymes typically remain above normal, but they may fluctuate. But it's important to know that all chronically infected persons carry the virus in their blood and have the potential to transmit. Next slide. So this is one of those typical first 100 days of infection that we are most commonly look at for HIV. But you can see for HCV, it's very different than what we're used to with HIV, where you have more intersecting lines of detection, because you have HCV RNA, you have P24 antigen for HIV, you have IgM, IgG antibody results for HIV, whereas for HCV, we have quite a wide window period. The HCV RNA will ramp up quite fast and is detectable in 1 to 2 weeks. Here we illustrate that HCV core antigen, which we'll talk about more in the discussion here, but it pretty much shadows the HCV RNA detection. But there's still a long, an extended window period before we see total anti-HCV tests that can pick up antibodies in about 6 to 8 weeks, unlike what Monica showed with the HIV. Next slide, please. I won't go over all the past recommendations, but clearly there's been a number of HCV recommendations over the years, but the two most recent wanted to spend a little bit more time with. The MMWR and the recommendations to identify chronic hep C among individuals born in this birth cohort was August of 2012, and it was actually amended from an earlier recommendation that was risk-based. But so now this includes this one-time testing of HCV for all persons born during 1945 and 1965, and the data showing a higher prevalence in that age group was really the catalyst for this recommendation. But this recommendation itself somewhat stimulated other HCV testing guidelines as well as clinical practices, one of which being less than a year later, another guideline coming out specifically describing some of the changes in HCV testing that needed to be brought forward, and of course the new diagnostic algorithm incorporating those assays. So in May of 2013, the one that primarily that we use in the laboratory a lot because it's really the focus is on the testing. About 4 different events went into that issue where HCV recombinant immunoblot assay, the REBA commonly known, was discontinued prior to the recommendation. And that opened the door for RNA testing, which before this point in time may not have been as common as it was, just prior to these recommendations. So it left the door open for RNA testing to come in and take its place, the place of REBA. And that also allowed us to discontinue the use of the screening antibody signal cutoff values, interpreting that as confirmation. And we'll talk more about that in a few minutes. And then the fourth factor was this, it also illustrated the first FDA approval, first and still the only FDA approval of a point of care CLIA waived whole blood rapid test for HCV diagnosis, which was approved in 2011. So now we have really an emphasis to identify more current HCV infections, and also gave us a platform to promote the improved antiviral agents against HCV. Next slide, please. So the recommended testing sequence is that you begin with an FDA-approved immunoassay to test for HCV antibodies. And unlike the assay, the long list of assays that Monica was showing for HIV, well, we do still have a number of assays. In this case, we have, looks like 6 different laboratory-based assays for antibody detection, both automated and manual. Another click, please, Jasmine. Or one, there you go. And we also have one, the one FDA-approved rapid test called the OraQuick HCV by the company's OraSure. So all 7 of these assays, because they're total anti-HCV detection, their performance is pretty much equivalent to each other. So whichever assay is used for screening really doesn't have a significant advantage over the first, other than the setting that you're in, either laboratory or point of care. Next, I would emphasize that the OraQuick is a finger stick or venipuncture whole blood only. It's not for oral fluid use as it is for HIV OraQuick. Next slide, please. So if the antibody test is reported, they're either reported as reactive or non-reactive. And if it's non-reactive, it just signifies that there's no HCV antibody detected. If it's reactive, the result can indicate a current HCV infection, a past or resolved infection, or a false positive screening result, of which we want to recommend, and the guidelines recommend that if at all possible, you want to reflect directly to RNA testing as soon as possible for all HCV antibody results. And there's at this time no additional need to test for antibodies to confirm. Another click, please, Jasmine. So I just want to bring this up again, that the signal cutoff ratios and thresholds for HCV antibody testing, which were actually part of like a 2003 guidelines, are no longer recommended for HCV supplemental testing and reporting to healthcare providers. Next slide, please. So if the screening test is reactive, your next step is an RNA test, and if RNA is detected, current HCV infection is present. If RNA is not detected, the interpretation is no current HCV infection. So at the time of the guidelines in 2013, there was primarily the RNA tests that were available were quantitative tests. Since then, we now have an assortment of qualitative, quantitative, and what we call dual intended use claims. The top two assays shown on this table, and this table is also in one of your documents that's in the reference list of the 2019 guidelines about HCV testing for laboratories. The first two are qualitative and maybe in some limited use around the country. If you switch down to the bottom two assays, these are purely quantitative disease management tests only, but they both have revisions in development outside the U.S. that eventually will come into the U.S. And the revisions for these two quantitative assays to replace them would now fit the role of the three in the middle. You can double click again if you would, Jasmine. So these three in the middle, there are two manufacturers for three assays, and they have what we call dual intended use claims. Very, very useful in that in the algorithm, they're for diagnostic, that you can be used for diagnostic as well as the clinical management. So the advantage here is in this the algorithm for HCV, you could confirm with one of these three tests, and besides completing the diagnostic confirmation, it can also provide a baseline quantitative value for further clinical management. Next slide, please. So this is the schematic of what I just described, and I think this is also referenced in the reference sheet, where you can get exactly just this schematic for if you wanted to put it in some kind of SOP manual or put it in your laboratory, or you can retrieve it directly from the recommendations. And I'll go over the small print here next. Next slide, please. So there are some considerations for repeat HCV testing. For persons with negative HCV antibodies and potential HCV exposure within the past 6 months, HCV RNA testing is recommended. For immunocompromised persons with negative HCV antibody results, again, RNA testing is recommended. And for persons with positive HCV antibodies and HCV RNA not detectable, repeat HCV RNA if there's a potential exposure in the prior 6 months, or if there's clinical evidence of the infection is present, or there's concern about the specimen integrity. And we'll talk about that in a slide coming. And also the fourth scenario would be for persons with a positive HCV antibodies and RNA detected but not quantified. We recommend the guidelines recommend HCV RNA repeat testing in 2 to 4 weeks. And this scenario is shared by at least 2 of the viral load assays that I had on a previous slide, where their limit of detection is actually slightly lower than their lower limit of quantitation. So if the value of the specimen lands into that section there, that range, you may want to repeat HCV and RNA. If this is truly like an acute case, testing a few weeks later will give you probably a RNA value that's above the lower limit of quantitation. Next slide, please. Another resource, this is very just off the press this year, is from the APHL, is an interpretations for HCV viral results guidance for laboratories in January of 2019. It's also on the reference document. But this actually highlights the additional support for the 2013 guidelines and gives you very detailed reporting assistance with those cases that are detectable, not quantifiable viral load RNA results. And it also provides a few more best practices for repeat HCV testing. Next slide, please. So on this slide, I wanted to really emphasize that the HCV diagnostic algorithm is basically a 2-test algorithm, where what Monica described for HIV is basically a 3-test algorithm. It can go out to a 3-test algorithm. But for a 2-test algorithm, and we have the screening test as a serology test and the confirmation is an RNA test, it's critical that the laboratory, the program, and the providers all communicate as to the proper specimens to be submitted for diagnostics. Fortunately, for those three assays that have dual intended use claims, they happen to be FDA approved for serum and plasma, but not all viral load assays. If that's what's going to be your second test in the algorithm, that specimen requirement may be very different than your antibody requirement. But a single specimen may be used for antibody and RNA testing if the requirements for both tests are the same and are met. There may be still opportunities where 2 separate specimens, one for antibody and one for RNA, may be collected, especially if RNA testing is done maybe at another site. If you get a positive for your screening test, but they should be collected at the same time of the initial testing. If ORQuick, so if the specimen and the individual is pre-screened with an ORQuick HCV rapid test using a finger stick blood and it's reactive, a venipuncture specimen must be collected for RNA testing. And as I mentioned at the beginning, if RNA testing is indicated and the initial specimen is not suitable, you would like to avoid that by having this good communication between the laboratory and the program. They need to know which test you use in the algorithm and be able to disseminate that to either your county health departments or your other product providers, so that we can avoid having to go back and say, well, the screen reactive, but we need another blood for our confirmation, and we're missing times that we could link people to care. Next slide, please. Like Monica said, there are challenges with HIV testing now with individuals that are on PrEP, and that can be extended also to HCV testing. Both the PrEP guidelines for 2017 as well as the Infectious Disease Society of America guidelines recommend baseline anti-HCV screening among MSM prior to PrEP initiation. However, from that point forward, you may find recommendations that are not really uniform to each other as to how often to further screen for HCV. The IDSA actually has in their guidelines that HCV testing is at least annually to follow-up PrEP visits. And recently there was a study in the Journal of Infectious Diseases, and it's cited here. We know that sexually acquired HCV infections among HIV negative MSMs are rare. However, in this study, they concluded that an increase in sexually acquired HCV among MSM on PrEP may be attributed to more sex partners and more IVDU use after starting PrEP. So this is quite concerning. And as we start seeing more studies like this, not just with HCV, but syphilis, not even a subject for today, but maybe we may start seeing, since individuals on PrEP are being screened and monitored every 3 months while they're on the medication, we may see more frequent HCV, particularly screening in future recommendations, I would think. Next slide. So HCV test on the horizon. I think we can anticipate that we're going to see more traditional HCV RNA NATs with dual intended use claims, because once the sort of barn door is open with 1 or 2 assays having a market, others may want to try to get some of the market as well. These 2 that are listed are the 2 that were on the bottom of that chart that were purely viral load assays, but these assays outside the US are CE marked for both dual claim. So it's anticipated, we hope that both of these manufacturers, when they bring their products into the US, that they'll also bring that claim with it as well and give us more variety in being able to diagnose and provide a clinical baseline all at the same time. And likewise, with HCV, as it was for HIV, we have some rapid HCV NATs that are pending FDA approval. Patients may receive their results on site in less than an hour in a single visit. And clearly this would enhance some linkage to care. But of course, what hasn't been addressed on HIV as well as the HCV side is what will the expense be on these assays, as well as I think it's not real clear what the complexity level that CLIA will assign. Clearly, they would love to have a point of care application, but based on which rapid tests we're looking at, that may change or may have to be modified before they can get to that point. I think another slide, please. HCV core antigen immunoassays. That was in that original 100-day study slide. You see that the core antigen ramps up just about as quickly as RNA and extends out. And this assay may give us an alternative to RNA testing in the diagnostic algorithm one day, because it can be performed on the same HCV antibody assay analyzer. So this is a real benefit in that you don't have to have 2 large platforms. You can go from antibody testing to confirmation within the same analyzer. It is a marker for a current HCV infection. And likewise, there's none that are FDA approved at this time in the US. But there's been several studies on the Abbott assay that's probably the closest to being to the point of investigated and possible use. And the studies have demonstrated sensitivity of it in the 94 to 100% range among HCV RNA positive persons, and the specificity among the HCV RNA negative individuals as high as 100%. So clearly this assay has a potential for a cost-effective path for confirmation, on treatment monitoring, or SVR, determining sustained virological response. One more, maybe one more slide. Yep. So in summary, the 2013 CDC testing guidance for HCV changes in HCV antibody testing and provides a framework to identify current HCV infections for care and treatment. RNA testing should be performed on all HCV antibody reactive specimens, and the 2013 guidelines is not recommended at this time for diagnosis of an acute infection, HCV infection. But as with HIV, the future of HCV diagnosis will provide excellent opportunities to integrate early diagnosis with linkage to care and treatment and monitoring. So with that, I think that's it. Jasmine, one more time. Okay, and thank you. I'll turn it back over to, I think, Anne.
Hello, everybody. I'm off mute, hopefully. And Jasmine, do we want to try one more time and see how it works?
Go for it, Anne.
Okay. All right. Looks like at least I have power currently. So thank you all for Monica and Barry for those great presentations on the current status of HIV and HCV diagnostic testing. Hopefully it gave everybody sort of a good overview of what's out there, what to think about now, and maybe what to think about for your future. As we sort of wrap things up with the webinar today, I'm going to talk a little bit about sort of the differences between laboratory and point of care testing, and some more general ideas around laboratory testing and how to work with your public health laboratory before handing it over to Lisa. So this is a slide that's actually a table from the Integrating HIV and HCV Testing Toolkit, which was released in the fall of 2018 as a collaborative effort between APHL and NASTAD. So if you don't have that yet, it will be listed in the resource link at the end of this. And it's a really great tool for you all to take a look at. And so this is a table from that, and just sort of summarize a lot of the things you just heard from Monica and Barry in a more succinct, sort of quick to look at table. So I've highlighted a few things I just wanted to point out. So we do have the window periods listed here. And on the left-hand side is laboratory-based testing. The left column is HIV, and then the right column is HCV. And then on the right-hand side of that table is point-of-care rapid testing, and this is CLIA-waived tests in particular. There are some moderately complex rapid tests. So this is the CLIA-waived tests. And again, the HIV column and HCV column. And you can see there's a lot of similarities across the board between HIV and HCV. But so window period tends to be shorter for laboratory-based testing, particularly in HIV versus the point of care. HCV, they're actually, the overlap is the same. The next thing I want to point out is sort of detection of acute infection. So Monica, as you guys heard, talked through the ability of the laboratory-based antigen antibody assays to detect acute infection for HIV, but the CLIA-waived testing is not as good at that. And for HCV, they both can detect acute infection, although as Barry mentioned, the algorithm isn't really set up for that. It's more sort of able to detect current infection. The other thing I wanted to point out is the idea of testing for multiple infections. So obviously you heard today both about HIV and HCV. We have this integrated toolkit. So sort of really trying to think through how do we test for both pathogens and more in a given setting. And so with laboratory-based testing, so with both of them, you can test for multiple pathogens at the same time. But for laboratory-based testing, you very well might be able to use one sample and test for multiple things. And so just a quick sort of look at another table. If this works, yeah. So this is a table that APHL put together, and again, this is included in the Integrating HIV and HCV Testing Toolkit. It looks a little bit different in there. It's appendixes B and C. But just to give you guys an understanding of what this is a list of every serologic assay on the top in teal, and every molecular assay on the bottom in red. And then in the toolkit, there's actually a third page that is the rapid testing. And it shows the different platforms and what testing is available. So we'll come back to sort of why that will be important in just a moment. But sort of back to the table, also want to point out some potential positives of the point of care rapid testing. One is delivery of results, potentially in a negative person with a negative rapid test, they would get that result the same day and be out the door. In the case of a positive result, you may or may not be getting any improvement over delivery of results if you have to do subsequent testing as compared to the laboratory test. But just something to think about is delivery of those results. Another thing is the FDA-approved specimen type. So again, Monica and Barry talked about serum and plasma being approved for laboratory-based testing. One advantage of point-of-care rapid testing is that you do have the option to test whole blood. Again, there's a disadvantage of that with the window periods, but just some things to think about as far as your settings and where you're actually doing testing and what trade-offs you're willing to make. And so just some things to think about. And so I wanted to sort of just draw folks' attention to thinking about some things about when and where might be a good time to collaborate with your public health laboratory. So I think most of the folks who are joining us today are not our laboratory colleagues. And so when might you want to talk to your laboratory colleagues? So for example, you might want to test for a specimen that's not FDA approved. For example, dried blood spot testing is getting a lot of interest, particularly in the opioid epidemic, and it's becoming an interesting sample that people are trying to get access to testing. But that's a discussion that you'll need to have with your laboratory, and a great discussion to have about whether that's something that's feasible for them to do and how that would work. That's one place that might be a good thing to talk to them about. Another is sort of, as I mentioned, how to test a single specimen for multiple pathogens. So we mentioned HIV and HCV in the toolkit and other methods. We also talk about testing for STDs, particularly in the context of PrEP and in other high-risk populations. You may want to be testing a person for all three of those sort of disease areas. And so what is the best way to draw a single or two samples and test for the most number of pathogens that you think your patient population is at risk for? A question to sort of ask yourself is, do you know what testing your laboratory is already doing? Do you know what platform they're on? Do you know what other assays are available on that platform? Could they be doing additional testing that they're not right now, and what would that take? And, do both parties want to be doing that to further your public health goals? And so the next question is sort of aligned with that. Do you know what testing they might be able to do with the equipment and staffing they already have? And then my last question here, and I'll follow up this with some more information, is did you know that public health labs in the U.S. have access to reference centers for both HIV-1 NAT and HCV NAT? So both Monica and Barry talked about the importance of those tests. And data I'm not showing here today, we have a lot of labs that submit samples to our HIV-1 NAT reference center, but there's a lot of labs that don't have access to HCV NAT that could potentially take advantage of a new reference center we've offered. And so just quickly here, so all U.S. public health labs, so if you are from a jurisdiction and associated with a public health laboratory, that public health laboratory is eligible to ship specimens to reference centers supported by APHL, both for HIV-1 NAT and HCV NAT. Both the testing and the shipping are currently covered at no cost to the public health laboratory. For the HIV-1 NAT program, the specimens must be tested at the public health lab. They need to be reactive on an HIV antigen antibody or HIV antibody screening test, and then negative or indeterminate on a supplemental antibody test to be eligible. And then they would go on to have the HIV-1 NAT as described by Monica in the first half of the presentation today. Alternatively, for the HCV NAT project, specimens that are tested at a public health laboratory that were reactive on an anti-HCV antibody screening test would be eligible. In addition, if you had high-risk patient population that they tested negative on the screening test, but you have strong suspicion or reason to believe that RNA testing would be valid, that is also allowed with sort of consultation in that program. So if these are things that you aren't sure if your lab is already doing, or you already know, but they maybe aren't doing the HCV one, certainly talk to them, see if they're already enrolled, or if you think that this could be beneficial to both you as the program as well as your laboratory. And then my information has been included here today, and I am the one responsible for enrolling folks into either of those reference centers. So let me know if you have any additional questions, and I'm happy to address those. And I think that's all I had. So I'll turn it over to Lisa.
Thanks so much, Anne. Jasmine, I think I just have one slide, so if you would be so good as to advance it, I would appreciate that. Okay, 2 slides, one more. Sorry. All right, so I hope that we have been able to highlight for all of you that we have a lot of different options for testing for HIV and hepatitis C. And there is the potential to use the various technologies to help us achieve our program goals and objectives. And those are highly varied, I think, across jurisdictions based on a number of factors, including our resources, our internal capacity programmatically and surveillance and laboratory, the populations that we serve, et cetera, et cetera. But we may want to look at different testing technologies, and I think we're encouraging you to do this, to see how you can enhance your testing and linkage services. And I think this is particularly apt as we are moving into a period where we expect some influx of resources around the eliminating HIV epidemic funding. I think we are coming close to wrapping up the viral hepatitis prevention cooperative agreements. And so there's an opportunity, I think, to begin rethinking or thinking through how we might want to use testing technology to enhance or focus particular areas of our program. And so what you see here on your screen is another tool from the integrated testing toolkit that Anne referenced. And while the testing toolkit was specific to integration or supporting integration of HIV and hepatitis C, the tools in it actually can be used for either HIV or hepatitis C testing and linkage programs independently or as strategies or tools to support an integrated strategy. And so what you see here are 3 buckets or domains of the factors that we encourage you to consider as you are thinking about how to use different testing strategies, technologies, and how those technologies are deployed for your programs. And those are the population level factors such as incidence and prevalence, client level factors such as the likelihood of acute infection or client preferences, costs and readiness to test and access treatment. And then, of course, the all-important program factors, both within the state or the local health department and or the providers that you support or collaborate with to be able to implement HIV and hepatitis C testing toolkits. But in general, in selecting a strategy or strategies, and I will say that it isn't necessary to select only a single strategy for your jurisdiction or program. You may want to select or use multiple strategies depending upon some of these factors. But in general, you want to select a strategy or strategies that gives you the most accurate results that are possible. You want to identify infection, whether it's HIV or hepatitis C, as early as possible so you can facilitate more timely treatment access. And you want to select a strategy which is consistent with your program objectives or priorities. So, for example, if you want to implement HIV PrEP for MSM and or injecting drug users, you want to be thoughtful about the testing strategies and technologies that are going to most help support that implementation. You, of course, also want to be responsive to what the population needs and preferences are, and you want to do something that's really within your capacity. And I want to encourage all of us to think more broadly about resources in particular, because what we think about often when we think about expanding testing is, where are the dollars coming from? And I think that one of the things that we are encouraging you to look at today is how can you leverage extant resources and capacity, human and fiscal resources, that already exist within your health department, within your public health laboratory, and within your HIV and your viral hepatitis programs. And I think that's why Anne and Barry and Monica in particular were encouraging you to reach out to and establish a collaboration with your public health laboratory in particular, and especially getting ahead of the ending the HIV epidemic and the upcoming recompete, I think, of the viral hepatitis cooperative agreements, is there may be some laboratory capacity or interest that is currently underutilized. One of the things that Anne didn't mention but could is that I think about 2/3 of public health laboratories actually have hepatitis C screening capacity, but that is woefully underutilized. And so that's something to explore, how you can expand that capacity to do hepatitis screening and potentially do it in a way which allows you to screen for both HIV and hepatitis C. So those are the formal remarks that I think that we have today. There's a number of questions that have come in from the chat. I'm not sure if we have gotten any hand raising, Jasmine, but I will go ahead and start with some of the questions that have come in from the chat. An earlier question came in, I think specifically to Monica, and the question was, is all the data in the software de-identified? Unfortunately, the person asking the question is not on the webinar or had to log off, but I think that they were probably referring to the Geenius software in your presentation. Is that something you can address, Monica?
Sure. Yeah, there is no identifiable data that Geenius uses. So any sample gets assigned an accession number, and then throughout the testing process, the sample is always followed using the accession number. So in any type of instrument is going to only incorporate that accession number into the system when it's reading results. However, what's nice about Geenius is that it can interface, you can import results directly into a LIMS system. So in the LIMS system will be where that the patient level data is kept. And what's nice about that is that means that you can reduce the number of errors there might be from having to type in test results. They can just be directly imported or electronically transferred into the LIMS system, but there's no identifiable data. The reader is really just a little camera, and the software is really just measuring the intensity of bands.
Thank you, Monica. Another question that has come in is, if you were to set up confirmatory whole blood HIV test on your EHR order options, would you name it Geenius, Architect, or HIV 1-2 AGAB? And I'm guessing that because this is referring to the confirmatory test, it is actually the Geenius test. Monica, I'm not sure if you or Barry can answer this, but if you'd like to take a shot.
Well, this is Monica. So I'm not sure about confirmatory whole blood tests. So I actually think that Geenius is approved for whole blood in its package insert. But if you were to set up whole blood in your EHR, I guess I'm just not entirely sure what they're asking for here.
I mean, I think that the way that it often appears in order sets in EHRs is actually HIV 1 AB and HIV 2 AB, and it often has a differential, but that varies by coding within EHRs. But I think that generally it gets set up as an AB1 or AB2 only test. That's certainly something we can look into more to get a better understanding of what the question is. There is a question here about hepatitis C transmission during the acute versus chronic phase. Can hepatitis C be transmitted in the acute phase as opposed to chronic phase?
Yeah, this is Barry. Yeah, there's several places in the presentation where it illustrates that it is, as long as you have RNA present, it should be transmissible. As you know, there's the acute stage was defined as, in one way, as a positive or quantifiable HCV RNA with a negative HCV antibody. And then if you apply that to that graph showing the first 100 days of infection, that could be up to like 6 to 8 weeks of that condition. So there's plenty of opportunity there where that could be transmitted. In addition, I would draw your attention to the very last reference in the other resources on the document, where it talks about HCV in key populations, and it also talks about HCV incidents from individuals with MSM individuals, getting their infection quite early. And also, in one of the slides, there was a reference to the Price article in the Journal of Infectious Diseases, and it also speaks about populations, their study were San Francisco and New York City, again, of individuals, incident HCV cases, again, due to their MSM and the PrEP interactions. Hopefully that answers.
Thank you, Barry. I have a clarification on the order set. On the order set, what name would you give to the test you are ordering when you draw whole blood to confirm a preliminary positive rapid test? Would you order a Geenius, an Architect, or an HIV 1-2 AG-AB?
So if you do a whole blood rapid test and you're submitting a sample to the laboratory for confirmation, they are going to want to start at the beginning of that laboratory algorithm. So that would be the HIV-1 antigen antibody test, and they will need to process that whole blood to serum or plasma to perform that test. And then if it's reactive, they will continue through the algorithm. So they'll go on to Geenius and, if needed, NAT. So hope that answers the question.
Yeah, and this is Anne. I would just add that the specific test would depend on the laboratory. So it might specify Architect or it might specify BioRad's assay, but it would be hopefully an HIV 1-2 antigen antibody test, starting with that first step in the algorithm. Hopefully that answers that question.
And during your remarks, you referenced that there is an interest in sample types such as dried blood spot, and that might be to facilitate testing among individuals such as injecting drug users where you can't easily perhaps obtain a sample through venipuncture. Can you or Monica or Barry comment on what that practically entails, being able to do in a laboratory to be able to submit a dried blood spot in brief?
Yeah, Monica or Barry, do you want to take that?
This is Monica. I can address it. Well, right now there are very, very few HIV tests that are approved for dried blood spots, and I don't think any of the hepatitis C tests are. The only HIV tests that are approved for dried blood spots are really the HIV-1 Western blot is approved, and a first generation or IgG only AVIAC ELISA test. So those are not really being used in laboratories. Of the tests in the algorithm, a laboratory would have to conduct a validation study. So that can be fairly extensive. They would have to determine what buffer to elute that dry blood spot in, determine, the conditions for eluting the blood off of the filter paper, and then they would have to compare how the test performs with the dry blood spot to an approved specimen type and run all of the sensitivity and specificity, perhaps, and reproducibility studies, and then determine if the test is functioning properly, then the lab director would have to review all that data and sign off on it.
All right. Yeah, if I can add to that, like Monica mentioned, there's only one FDA-approved IgG antibody assay on the market, and the one Western blot. And the screening test is actually a microtiter assay, so it's an older technology. It's just HIV-1. You wouldn't be able to pick up HIV-2 with the assay, nor would you have the ability really to pick up an acute infection, because the timeline is quite back. The sensitivity probably is around like 60 days. So I wouldn't, at college we actually are able to do the testing, but not specifically for dry blood spots, but for oral fluid testing. But still, I would recommend, if there's any doubt, any suspicion of like an HIV-2 infection, or if the individual's had recent risk factors, you'd want to go to a more advanced antigen antibody screening test and the differentiation confirmation.
Right. And one thing, this is Monica, and one thing I'll mention about the antigen antibody test is I think it could be very challenging to validate from dry blood spots for antigen detection. So antibody detection, I think, can be done, and we know that we can also validate for RNA detection. I just don't know that we have as many tools and comparators for antigen detection, so I think that would be challenging. But
yes.
One more question we have. The CDC PrEP clinical guidelines has an algorithm stating using a rapid test is preferable and can be used as the only test if a patient hasn't had any signs or symptoms. Can you comment on that?
So when I looked at the CDC guidelines, they did an update in 2017, and it actually, in that one, it said that the antigen antibody test was preferable. So I guess my question is that the most recent update of the CDC guidelines? Or maybe we're talking about two different documents.
This is Anne. That's my understanding. It's the most updated one.
I just accessed it like last week, and the 2017 version, it says in two different places where it's either, it says on the algorithm chart, it has a yellow highlight over the antigen antibody test and says preferred, and in a couple of other places it states that as well for the antigen antibody test.
Maybe that's an important thing for us to try to clarify offline, so that, one, we're sure what the current version is, and two, there may be some room for interpretation of those guidelines. This is a question that comes up frequently, I think. I am noting that we have 2 minutes left. Jasmine, would you advance the last slide? I think there's 2 more, but if you can just advance the last one. I want to call your attention to the fact that there are a number of resources that will be available to you in the handout. We will send out a link to the webinar and the slides, so you will have those. And if you could all take just a couple of minutes to complete the evaluation, that would be most appreciated. And I know that there are once you've had a chance to digest this and think about it a little bit more, there may be questions that you have or technical assistance that you are looking for. And NASTAD is willing and able to support that. And I'm sorry, Jasmine, if you can go back just one slide, that will help me. So there are some other resources here for you that we wanted to call your attention to. There's the Diagnostics Conference that just happened in March, and there are a number of presentations that have relevance for for programs. I encourage you to browse through the abstracts there. We have, NASTAD has an annual technical assistance meeting, the super mega meeting that will be for HIV and hepatitis C, as well as prevention and care, that's scheduled for December in Washington, D.C. Anne, do you want to say anything about the Microbiology Collaborate?
Yeah, so I presume most of you are on the programmatic side, but we do have an option for your laboratory folks if they are not engaged already. We have the APHL Microbiology Collaborate, which is a community of practice focusing on laboratory issues, and any of our lab members are welcome to join, and you can email me if you'd like to be added. So if your lab folks are not on there, encourage them to reach out to me. And if you are a lab folk on the call, then feel free to join as well. And then lastly is just a reminder about the APHL CDC HIV HCV NAT, which I had mentioned earlier in the slides.
And if there are follow-up questions that you have after this about the webinar, Jasmine, what is the best way for folks to reach out?
If you want to reach out to hepatitis@nastad.org, then we'll be able to connect you with some of the panelists if it's relevant to them, or we can answer it directly.
All right. Thanks so much. I appreciate your time and attention this afternoon, and thank you to our panelists, and I wish you all a good afternoon.
Thanks, Lisa. Good afternoon, everyone.
Thanks, everyone. Have a great rest of the day. The slides and recording will be circulated to all attendees.